Hi. I think we're just about ready to start this session. There's nobody queuing to get in. I think everybody's in. So can I thank everybody for coming along this evening to this consultation session. And can I start by introducing myself first of all. My name's Nick Pennell. I'm chair of Plymouth Health Watch, and I'm here today as an independent chair for this session. And I work in a voluntary role, so I'm not paid for this, and so that does give independence. Health Watch, as you probably know, is the health and social care watchdog, and one of our key objectives is to ensure that there's adequate and appropriate and meaningful consultation with members of the public with regard to health and social care. So we're very pleased to be chairing this session, and very pleased to see that this session is taking place and keeping everybody informed, involved and updated in terms of changes to healthcare. Before going any further, I think I ought to go through the formalities. And if anybody needs the loos are through the entrance that you came in and directly opposite, quite easy to find. We're not expecting a fire alarm, so if the alarms do go off, just follow the signs. If anybody has any difficulties with access, there's a 30-minute limit here, and just stay in the room for 30 minutes, but everybody else, please follow the signs that will lead you to the area outside. If anybody wants refreshments, there is some tea and coffee over there. You should stay away from the bar whilst it's open until the session's finished, but tea and coffee is provided. I think I need to let everybody know that we do record these sessions. These sessions are recorded audibly, and the reason for that is quite simply so that any points that are raised by anybody during the course of the session aren't missed and could be included in the review and the analysis of the feedback that we get. So that's the main purpose of that. I was going to introduce the panel members next, but I'm going to let them introduce themselves just before the presentation starts, if that's okay, because I think they can do that a lot better than I can do it. Can I just direct everybody to some of the, for this evening, and agendas are on the table. The agendas are part of this package, the big double one, and they should be on the first page. And you'll see from the agenda that we're going to start with a couple of presentations that will be done by the panel members, and then we'll go into a question and answer session. And for the question and answer session, I'll roam around with the microphone and we'll welcome questions to the panel from all the participants here today. And then we'll finish with tabletop discussions, which will be facilitated. There'll be a facilitator on each tabletop who will note all the points that are made, and they'll be fed back as part of the consultation and the review. So I think without any further ado, I'll hand over to the panel, let them introduce themselves, and then take us through the presentations.
Okay, thank you very much. My name is Jill Champion. I'm one of the clinical commissioning leads for New Devon, CCG, and my day job is in Exeter. I'm a nurse partner down at the Foxhay surgery in Exeter.
Thanks. I'm Rich Mesner. I'm a GP in Budden Salston, and I'm another one of the clinical commissioners.
Hello, I'm John Renison. I'm a consultant at the Royal Devon and Exeter Hospital, excuse me, and I'm one of the associate medical directors there.
Good evening, I'm Janet Fitzgerald. I'm the Chief Officer for New Devon CCG, so one of the commissioners also, and I'm going to kick off with the first part of the presentation this evening. I'll stand up so it'll be easier. Apologies for the audio-visual. 5 minutes before we due to start, we didn't have any at all. So the fact that it's a lovely yellow hue is probably the least of our worries this evening. But thank you very much for turning out on a Monday evening in Exeter. Just to clarify what we hope to do this evening, so give some context on the development of the Devon-wide Sustainability and Transformation Plan. Go through why we're reviewing acute hospital and specialist services as part of that plan at this moment in time. The most important thing, though, is to hear your views on what is important to you. As Nick said, We will collect, tape, pick up everything that you say this evening and feed it in to the further developments on the Acute Services review. We'll explain how we'll use your feedback to inform the plans and how you can continue to stay involved as the Acute Services review develops. So a little bit of context. Devon, and by Devon I mean colleagues in South Devon and Torbay, Plymouth and the rest of Devon, working together on the Sustainability and Transformation Plan. We're one of 44 STP areas across the country. The plan, regardless of our financial challenges, which I think are well rehearsed and have been well covered in the case of change and are well repeated in all of the documentation as we go through each of the transformation plans, the plan would have been necessary without that. The Sustainability and Transformation Plan, will you forgive me if I call it the STP from here on in? It will shorten the presentation by about half if I use that instead of its full name all along. So the STP that we published late last year is a strategic framework. A lot of the detail is yet to be filled in. The Acute Services Review is the next step in that, filling in that detail. It's all about us being able to provide safe, sustainable, integrated support by 2021 within the resources that we have at our disposal on your behalf. The plan brings together a number of key benefits. Integrating health and social care more than we currently do, better meeting the needs of our total population, but in particular our ageing population. Meeting the ever-increasing demand on services and utilising technology to deliver services in many more modern ways. The STP is Devon-wide. All of these organisations listed on this slide are united in a single ambition to create clinically, socially and financially sustainable services. That's the backdrop to the whole of this transformation plan. As well as the organisations detailed with their sort of their icons, their logos, we have a number of key partners as well, and they're listed at the bottom of this slide.
Excuse me, I can't see that.
Sorry, you can't see it.
I'm blind.
Okay.
The guy's not here.
I will read it out to you as well. So, as well as the main partners, and that includes Devon Partnership Trust, Royal Devon and Exeter Trust, Northern Devon Healthcare Trust, South Devon and Torbay Clinical Commissioning Group, New Devon Clinical Commissioning Group, Torbay and South Devon Trust, Plymouth Hospitals Trust, South West Ambulance Services Trust, and the four councils, that's Devon, Torbay, Plymouth, and the community interest company, Livewell. Our key partners, this is not an exhaustive list, but the ones that we've listed today: Care UK, more than 160 GP practices, Devon Doctors, NHS England, Health Watch, both Devon, Plymouth and Torbay, and Virgin Care. I'm now going to play a short video that recaps on the case for change.
There is already much to be proud of about health and social care services in Devon. Staff work hard to provide good care, local people are relatively healthy compared with other parts of the country, and local organisations already work together to meet the needs of local people. However, services are not keeping pace with the changing needs of local people, and it is becoming increasingly difficult to make sure that local people have access to consistently high quality care that is affordable and sustainable. There are a number of reasons for this. People in Devon are living longer, with increasingly more complex care needs that require more support from health and social care services. Some people have more health and social care needs than others. 40% of local people use almost 80% of health and social care. There are 400,000 local people living with one or more long-term conditions, and their needs are complex. Around 150,000 people have a mental illness. Doing nothing is neither affordable nor clinically sustainable. We will be more than £500 million in the red by 2021 if nothing changes. Although there have been some local successes in changing the way services are delivered, there are many challenges facing health and social care in Devon.
There are health inequalities across Devon. A person living in certain areas of Ilfracombe is expected to die more than 15 years earlier than someone living less than 2 hours drive away in Newton Poppleford and Hertford.
Local hospitals are finding it difficult to deliver services for some of the most seriously ill people. These include stroke, maternity, A&E and children's services.
Less money is spent on health and social care in the most deprived areas. Over 10% less is spent on healthcare for each person in West Devon compared to North and East Devon, even when age and deprivation is taken into account.
There are too many people in hospital beds who don't need to be there. The longer people stay in hospital, the more likely they are to get complications. It is also expensive to keep someone in hospital when they don't need to be there. The main reasons for delay are people waiting for health or social care in the community.
Care needs to be more person-centred and coordinated, especially for people with more than one long-term condition. People do not get enough support to be independent and are going into hospital when this could be prevented. This is particularly important for end-of-life care, where most people would prefer to die at home, but only a quarter are able to do so.
This is also true for children. There are high levels of demand for child and adolescent mental health services, and there are still far too many children in care or in highly specialist placements, often many miles from home.
Services could be run more efficiently across Devon. Tens of millions of pounds is being spent on areas where staff may be able to provide the same quality of services but more efficiently. Too much money is being spent on temporary or agency staff in hospitals.
Around 95,000 people with a long-term condition also have a mental illness. These people consume a large proportion of the health and social care budget but still achieve poor outcomes. They are also more likely to die earlier in life compared to people without a mental illness.
There are difficulties with recruiting and retaining staff at all levels, making it hard to provide comprehensive and high quality services. Many staff are due to retire in the next 10 years, and local organisations already have high levels of vacancies and staff turnover in many areas.
People in Devon deserve health and social care services that are of the highest quality and are delivered as locally as possible. Local people should be supported to take responsibility for their own health as much as possible. If people do become ill, they should sit at the heart of a proactive, person-centred care system. Achieving this kind of transformation with the funding that is available is not an easy task. But by working together, the NHS and social services with other public, private and voluntary sector providers of care can get the best possible outcomes for local people.
Thank you. Hopefully that recapped on the case for change that we published almost a year ago. and is also summarised in the STP published at the end of last year. Everything that we're doing is focused on 3 main areas. Improving the health and well-being of the whole population that we serve, delivering safe and high quality care. We know that we have unexplained variations in quality in different areas, both geographically as well as in service areas. We need to ensure that mental health is prioritised in the same way that physical health is. And we've been working on a strategy for some time that places the best bed in your own bed at the centre of what we do in terms of integrated care. And the third aspect of what we're working on is providing cost-effective care. The do-nothing scenario, if we didn't transform, we just carried on as we are now, not addressing the inequalities, the growing demand, the ageing population, we project that we would be more than £500 million in the red by 2021. The plan spans a 5-year period. The STP outlines 7 areas of priority, starting with prevention and early intervention. So making sure that prevention is at the heart of what we're doing. Integrated care, health and social care, and this includes the recent CCG consultations both in South Devon and East Devon on the new model of care and community-bedded services. Our third priority is primary care, supporting primary care so they can support and implement the new model of care, implementing the GP forward view and making sure we have the right investment in primary care and the right access across the whole of Devon. Mental health I've already mentioned, making sure that that is prioritised, that is properly resourced, that is available for all of our population, no matter what their age or their geography. Then acute hospital and specialised services, and that's the bit that we're concentrating on this evening. I'll hand over to John shortly, and he'll take you through the 3 areas that we've chosen to look at in the first instance, the things that the clinicians have identified as the highest priority and the highest vulnerable to not being sustainable going forward. Productivity, we have to make sure that we use every pound that's given to us by the government of the day in the most effective way possible. I know at many of the events, we had it when we were doing the Your Future Care, and I'm sure colleagues in South London and Torquay also had the question when they've been consulting recently about the fair shares allocation and the money that comes to Devon. As health senior managers and senior clinicians, like you, we make representations to those that can influence that all the time. But until that is addressed, we have a responsibility to make sure that we use the resources that are given to us by the government of the day. And then last but not least, children, young people and families. You heard in the case for change a particular area, child and adolescent mental health. But ensuring that children's services are safe and effective is a high priority for us. I'm going to hand over to John now, and he's going to take you through the Acute Services review in a little bit more detail.
Thank you very much. Let me just start by reiterating the point that this is the first step of reviewing some hospital services, the acute hospital services, the front-end services that people feel very vulnerable if they don't feel that they're running it very effectively and efficiently for them. There are a number of concerns which are relevant to lots of different areas of practice. There is an increased need for treatment. We have an increasing size of population. We have an increasing ageing population. People live longer and have time to develop more problems and become more acutely ill. The treatment and care we can offer those people is better. There are more options, there are more treatments available. Those people may have treatment for many, many years longer than they would have done previously in the past. In the past, we had hospital services which were designed for the situation as it was at that time. That is not always the case now. It's not the case where the populations are necessarily cited even. And we do need to design services based on our population needs now. We have to be able to have services which are flexible enough to develop, to be able to introduce the best of current practice, to offer our population the best possible treatments that are available at the time, and as a consequence of that, to give them the chance of the best possible results. We are also required to meet NHS and national targets. These are not things which are plucked out of thin air. These are things which are developed with consultation with members of the public. These are what people feel should be reasonable waiting times, etc., and quality standards that we should meet. And one of our greatest challenges across all areas, and in these three areas particularly, is the ability to recruit and retain suitably qualified and specialist staff who can offer those best quality services. So, taking them all individually, each acute services review is being led by one of the medical directors, so these are being clinically driven reviews. The hospital urgent and emergency care review, I think everybody is aware of the publicity which this year has been highlighting the increasing demands on ED services, the increasing numbers of patients attending ED services, and the increasing pressure that puts on the services to deliver the 4-hour waiting time, which is one of the government's key waiting time targets, quite rightly. Staffing shortages across the whole staffing spectrum are very acute in ED departments, not only in the medical staff. It is difficult to recruit consultants. There aren't enough trainees coming through to consultant level to fill all the vacancies. There aren't more trainees to fill increasing number of spaces that you need to keep services running at higher throughput for longer periods of time, 7 days a week. Of course, this then leads to shortages and the inability to then flex the services if you're running your service at the maximum possible staffing at all times. When things get busier, when you have a time when things are very much busier, you have no flexibility to cope with that increasing demand. Therefore, the consequence of that is that patients attending the ED departments will inevitably wait longer to be seen, and in addition to increased numbers of patients and then waiting increased length of time, the types of patients who are coming into the ED departments are increasingly complex. So many of those patients not only, they're not all the walking wounded you might sort of describe. They are people with complex pre-existing mental health needs, and the ability of those ED departments to cope with that whole range across the whole spectrum is very much challenged. If you get the wrong people in the wrong place with the wrong staff or not enough staff, what you then end up with is patients being shifted around inappropriately, either within a hospital or possibly even transfers between hospitals. And again, that's something which we're all trying to avoid. Thanks. Stroke services. Stroke is one of the 3 greatest concerns that members of the public feel and have voiced about their healthcare for the future. If you ask people what are the 3 what things worry you most, stroke is top of that list. Heart disease and cancer are the 3 greatest worries. And it is a truth that access to the right speciality treatments, access quickly to those treatments, improves patients' outcomes. So getting people to the right place to have the right treatment as quickly as possible improves the long-term outcomes following stroke. We in this area do not have enough specialist stroke consultants, specialist trained nurses, and again there is a shortage of trainees coming through the system to fill the vacancies. Different hospitals in the area have different approaches to how they manage acute stroke. That will of course lead to some variation in treatment outcomes and also in the cost of those treatments and cost of the long-term outcomes after stroke. If you want better outcomes, you need to have the ability for these specialist teams to be involved in public education, public awareness. You may have seen the sort of campaigns on the television in encouraging people to come early if you think you have a stroke, and also outlining the signs of a stroke. If you increase public awareness of a potential problem, you will increase the number of people who attend hospital because they might have a stroke. A lot of them might not, but it's the right thing to do. We need to be able to provide the service for the patients who also feel they may have a problem or may have had a stroke. But again, the critical point is a shortage of the right staff in the right places. Maternity, paediatrics and neonatology services. That sounds like a lot, all put together. It is. The problem with these 3 is they are completely interdependent. They're absolutely interdependent. You cannot separate one of those and just review it on its own without affecting the other 2. But the problems are the same for all 3. There is a shortage of staff, especially in paediatrics at consultant level. Obstetrics and gynecology is increasingly difficult to recruit to. I'm actually a consultant gynecologist. I've worked in Exeter for 20 years. And across the hospital, across all specialities, Exeter was always a place where we could get recruits to consultant posts. That is no longer the case in some specialist areas, especially in paediatrics, where we've been advertising for posts and failing to get applicants. If this is one of the most popular places in the country to work, we can't get applicants for consultant posts in some specialities. There is also a shortage of trainees. So the number of trainees being trained has been reduced. So the number of staff coming through training is reduced. The number of those trainees who work part-time has rocketed. And that's a demographic fact. It just is a demographic fact that we have more, especially in these specialities, you obviously attract more ladies, more female trainees. They are more likely to end up wishing to train part-time because during their training is the time they will have their families. It is just a fact of the demographics of the input into medical schools and as people come through training. That leads to gaps in the trainee rotas, which are very difficult to fill. And you have to fill those with temporary locum staff. They are not so reliable. They come for very short periods of time, And the impact on the health community is that they are phenomenally expensive compared to normal contracted staff. But you have to keep them because you have to keep these services available 24 hours a day, 7 days a week. The issue in maternity of choice is also paramount. And we have a good deal of variation across Devon. In Torbay, they have one of the highest home birth rates in the country, and have pride themselves on this quite rightly. In North Devon, they have no community delivery units. There is a hospital delivery unit, but there are no community units. In East Devon, we have 3 community units as well as a hospital. In West Devon, there is the Plymouth Hospital. So there is great variation across Devon in what is really available for women and their choices around birth. And again, we have patients who for various reasons have more complex health needs, who have more complex requirements. We have many children with very complex health needs who need that specialist care, and you cannot offer necessarily the very specialist care that would offer the best treatments and options for patients in every place. We have to then work together across the area to make sure that all the population is offered the right type of specialist care. So you see there's a sort of theme of staffing and complexity that runs through all of these, and these are the first 3 services that have come up to the watermark really of needing review. So I'll hand over to Rick now, who'll just run on to the next part.
Thanks, John. Why are we engaging with you? I think it's really important. No decisions have been made. This is the start of the process. We've heard about some really, really difficult challenges that we're facing in Devon, and the rest of the country are facing the same challenges. So we're going to have to come up with proposals to deal with these challenges. Now, when we come up with the proposals, we're going to have to look at how we develop those proposals by deciding what criteria we're going to judge them against. And this is the really crucial bit. How are we going to know that what we're coming up with is going to be what our population wants and needs, and is going to be effective for us going forward? And if we get the right criteria to judge our proposals, then we're going to make better decisions in the end. So to get the ball rolling, our clinicians have come up with various proposals that we think are important as the key criteria to judge our proposals against, to help us make decisions going forward. And what's really important, this is an opportunity for you to look at those criteria, to discuss them, to see if we've got them right, to see how important they are, and to think if actually have we missed some important areas. Should we be focusing on other things? Have we actually forgotten something? So we really want you to have a chance to look at the criteria that we've suggested and certainly think about whether they're right or wrong, how important they are, and have we missed any that are really crucial to you. Okay. So if we go through the criteria, these are the suggested clinical decision making. Safety sort of goes without saying really, doesn't it? I mean, our services are very safe, but we could always do better, and anything that we develop has got to be safe, and we've got to show it's safer than what we're doing at the moment. Feels as well that clinical benefit and improved outcomes feels fairly crucial. Then we talk about access. And access is on lots of different levels to the service, but it's about the ability of patients and carers to access the service as measured by a reasonable travel time and best outcomes. We've talked about stroke, and we've got some real challenges in Devon. One of the crucial things about stroke is that we want to see a patient with an acute stroke as soon as possible. We've developed clot-busting drugs, and if we can get those patients and get them treated within an hour and a half of the symptoms starting, then their outcomes are dramatically better. So how do we achieve that in a big rural area like Devon, where people might be a long way from some of the more major centres? So access has got to be thought about on lots of levels. John's talked a lot about the difficulties we've got recruiting staff, and it varies from unit to unit. So it's really important that we develop a service that is going to be sustainable, that we can have enough of the right staff in the right place. So if you have a really sick child on a Sunday night, you know that when he gets to the hospital, there'll be the right person with the right experience to deliver the safest and best care for your child. I think... Sorry? Oh, sorry. Thanks for that. I think training our future doctors, our future nurses, the future staff is really important. So however we set up the service, whatever it looks like, it's got to work in a way that supports the development of our future doctors, nurses, ancillary staff. We've talked about how difficult it is recruiting, so we've got to make sure the training is really effective, high quality, and attractive for people to come to, so otherwise we won't get the staff that we need in the future going forward. So training feels really crucial. We've talked about the cost. It's got to be cost effective. We've got a massive challenge. I've lost it again. Yeah. And I've almost finished this bit. We feel patient choice is important, promoting patients' ability to choose their provider and their treatment. And of course, the experience of everyone who uses the service. It's really crucial that people feel that they've been looked after safely, effectively, and with compassion.
Okay, let's move on to the next part of the session, but can I first of all thank the panel for those presentations, and can I also thank you for the openness and transparency that was displayed in that. I think HealthWatch certainly appreciates that, and in fact looks for that in these sort of sessions, so thank you. The next half hour or so is an opportunity for everybody here to make any observations on those presentations and ask questions to the panel of experts we've got here today. We've got about half an hour for that, and what I'll do is I'll roam around with the microphone and I'll ask anybody that would like to make a point, observation or question to raise their hand, and I'll try and get around as many people as possible. So you've got a gentleman here who's going to kick us off.
Thank you. Oh, gosh, thank you very much indeed. It just strikes me that the solutions to a lot of these challenges that you've outlined today are actually going to cost more money than rather than saving it. And okay, you can close maybe a few buildings, but people will have to be then hauled and transported to different places. But you still need more, same staff, if not more staff. You've got to train them. You need more, technology, more diagnostic equipment, and more treatment equipment. It all seems to me like it's all going to cost more money. And so how does this fit in with trying to save 557 million in the next 4 years?
That's a good question. Can I ask the panel who's first to answer that?
That's better. You are correct that a lot of new treatments require investment. If we could if we could attract the right people to come and work here, we would save money, because we're spending a lot of extra money paying over the odds for staff to fill the gaps, the temporary staff, so the locum doctors, the agency nurses, if we can get those gaps filled, we will save a huge amount of money, across the whole health community, by actually being able to do that. So it is a key area that we have to do, is to be able to attract and retain the right members of staff. As Rick said, making our hospitals the places where people will wish to come and train is critical. Being able to train them in those environments, you're more likely to keep them in those environments. And by doing that, we will actually reduce the cost of offering those best services that we can do. That isn't the answer to all, that isn't the panacea, but it is a fundamental component of these reviews, is to try and reduce the current spend on the above and beyond what we really need to be spending to keep these services running.
Can I follow that up? Do you want to take a follow-up, Manuel? It seemed to me that it was a recurrent theme throughout the presentations, this shortage of staff, and it's not working.
Is that better? It seemed to me that the recurring theme throughout these presentations is this shortage of staff and having to pay agency staff. So what I want to know is, why is there such a shortage of staff? Why aren't there enough people being trained? What's happened to make that, to bring us to this point? And what are you going to do to improve this? Because it's clearly a key point in the whole review. Oh, and Brexit, of course, is going to make it all a lot worse.
Somebody mentioned Brexit somewhere. Would the panel like to address that add-on question to the previous one?
I think so first of all is, what will we do the first key is retaining, keep the people we've got. So making the jobs more attractive, making the services as rewarding to work for as possible, and I mean that in a professional way, not financially. I think you've got to also bear in mind this is an issue we're trying to deal with across the whole of Devon. There are different issues of recruitment in North Devon than in Exeter. There are different issues of recruitment. If we can work out, for instance, how services can be delivered with a group of people working across an area rather than the old traditional, I work in North Devon, I'm a Barnstable consultant and I'm an Exeter consultant, that actually ends up with you being able to fill vacancies that have gone unfilled by making those jobs, sort of sharing the jobs and making it a service for the community rather than sorry, I was trying to a service for the community rather than just sort of people being isolated in their own sort of little bunkers, really. So that opens up the services and improves recruitment and improves the ability to retain people. I think I'll skip on to the Brexit. It is a fact we have recruited lots of staff from Europe and been able to recruit lots of staff from Europe, especially over the last few years, both medical, nursing and other allied healthcare professionals. And that has been a great success. Will that continue? Well, nobody knows, because we don't know what the outcome of the discussions will be. So we don't know what the outcome of the Brexit discussions will be to be able to answer that question. So we will have to bear in mind what is going to, what transpires, but we can't say what the impact will be at this minute.
Can I just say a little bit more in response to the gentleman's question over here? It isn't going to be easy. Some aspects of the plan to be implemented will require additional investment. In order to bridge the gap of nearly £500 million that we talk about in the case of change, we need to implement everything. We need to challenge ourselves on every aspect of the plan so that we're not just performing better than average, but we're performing as one of the best in the country. We need to really look at all of the areas that we're calling enablers, so whether it be the workforce planning and development area, whether it's the estate strategy, whether it's technology supported change, we have to do all of those things. We're going to need the whole 5 years to bring this off. It's not something that you turn around in a 12-month period. But most importantly, I think because there's kind of a follow-up question to this one, isn't it? Is why have we not done it before? So I think the whole area has tried really, really hard in the past, but what's different this time is that slide I put up with all of those partner organisations being fully signed up to this. We have to be working together to make this work, not competing with one another, not exploiting various aspects of the system that favours perhaps one organisation or one group of the population. We have to focus on the whole. If we do that, with a fair wind, with a fair chance of delivering this. And it is an aspiration and it is an ambition, but to not take the first steps in realising it would really be abrogating our responsibility. We'll see where we get in 2021, but we have to take those first steps now.
Thank you for those responses. There's a few questions over here. The gentleman at the back, I think, had his hand up first, so if I can go over there.
Thank you. I'd just like to pass an observation more than anything else with regard to the word you use, integrated care. And unless I've missed something, nobody sat on the panel amongst you comes from Devon County Council or anybody like that, who I would assume you would want to be talking about in great detail with regard to the introduction of integrated care. I could have jumped on the bandwagon with regard to the lack of professionals, and it's quite frightening that in 10 years' time, unless across the country the issues of professionals being recruited into the service will have very, very serious implications, whether it's surgeries or hospitals. But this question of integrated care is the other side, because you cannot complete the work you need to do within the hospital when beds are blocked by so many people because of the problems that are there.
Yeah, that's a fair challenge to the whole STP. They're not on the panel today because we're focusing on the acute services review. They're still important partners, but they're not the main focus of that. Colleagues in Devon, Plymouth and Torbay councils are full partners in this, working with us. They just don't happen to be here today.
If I can sort of say my involvement so far has seen the council members involved on those elements where it's necessary and appropriate, but as Janet says, this topic is slightly different. Can I move on? I think the gentleman here also had his hand up for a question.
Okay, so you said several times that the big issue is shortage of staffing and trainees. What are you actually doing to address that? It's hardly going to improve recruitment and retention by forcing staff, like the example you gave of Barnstable consultant to work in Exeter. That's not going to make someone want to work, is it? It's not realistic. I really, really hope that we're not just going to hand over more contracts to people like Virgin Care. Health and social care should be provided by public service providers, not farmed out to private providers. We've already seen in another part of the country where Virgin lost a contract, they're now taking the NHS to court. You know, this is just not the way forward.
It's an interesting question. I'll pick for question time on a Thursday, but would the panel like to address that?
Yeah, I'll pick up a bit about what actions are already being taken. So just to cite your example, not in any of these services, but in a different service, a vacancy in North Devon, consultant vacancy, it's been vacant for 18 months, 2 years. We can fill that now because instead of there being a service in North Devon and a service in Exeter, where the two basically deliver things completely separately, there will be an integrated service which delivers a speciality across North and East, so Exeter and North Devon, and that then allows us, that will encourage people to apply for the jobs. It's difficult to fill a job, a vacancy just working in North Devon, but if it's a job which is part of a team of people providing that service across the wider area, then you're able to recruit. There are other things you can do to recruit for where there are shortage of trainees. Concentrating on upskilling your other staff members, which can fill in some of the gaps that the trainees used to fill. Reviewing how you use the trainees within the hospitals to concentrate them at the places they need to be and take off them some of the jobs which have been sort of not necessarily requiring a doctor to perform them. All those things help to allow you to integrate your service and to make the best possible use of the trainees that you have available. The other thing is, again, I will reiterate, it is trying to encourage, make this a good place to be a trainee. Make this a good area for trainees to come and work, so they will want to come and work here. And the gaps, that will fill some of the gaps too.
Shall I address the sort of choice, independent sector aspect of the question? So none of the acute services review is about who gains the contract at this stage. We, like any other area, has to work within the legal framework, which includes competition and procurement law. What we would hope through the implementation of the STP is that in each of our areas, all of our population have the choice of a high quality NHS provided service. They will then make the choice themselves.
I think the first thing to say is recognise that we've got a very good workforce, both within secondary care and community services and in primary care. And we've got to work with our professions, nurses as well as doctors and allied health professionals and pharmacy, of course. I think there's an awful lot of good examples of work going on. And from a big picture, I think the thing that I've seen in the last 3 or 4 years is Health Education England working closely with our hospitals and also with primary care to look at delivering training opportunities for professionals that want to get on and change their professional role. I've also seen the trend towards bottom-up working with professionals, giving them some autonomy and greater intervention, greater integration with our workforce. So I can reassure you there's some things happening. I think bigger things have got to happen. But I think we must appreciate that most people at bed that work in health service do so because they want to live a good care. And we've got to harness that and ensure that they're working to the top of their professional ability safely.
Okay, shall we move on to the next? There's a lady here and a gentleman here.
Hello, mine's about accessibility. You're on about people travelling, but people that got strokes or anybody who haven't got someone that's with them won't be able to get for travelling and that. And like I said, a lot of people are on their own, so how are they going to get to the certain places?
I think that's really important. We would expect for something like stroke that it's an emergency, so an ambulance is going to deliver, the ambulance service will get you to the place where you need where you'll receive your treatment. And I think what we've got to try and work out, I think as clinicians, is how do we get somebody to the treatment that they need as soon as possible. So wherever they are in Devon, they get that treatment. So we've got an issue, as you say, about access, and that's why the ambulance service is one of our key partners in all this, because they're going to be absolutely crucial in delivering that side of things. But then we've got a separate issue about access, that if you're in hospital with a stroke and you might be there for some time, we've got the family and the carers, and how will they access the unit. So we've got a lot of different difficult issues that we're going to have to balance, and this is part of why we want to do the engagement, because you've got to help us. You've got to help us with this. We're going to have really difficult challenges to save the money, as the gentleman first highlighted, so that we can stay sustainable as a healthcare community. But on the other hand, we've got to really deliver top quality care that's safe. So we've got access that's going to be difficult on lots of levels, but that's why we've got the ambulance service as a key partner.
Do you still have the hospital card, or even like if I'm going to get a taxi, or just anything that can help people that are isolated?
When we get to the stage in the proposals where we have definite proposals to measure, we will do a full equality and quality impact assessment, so we know exactly how people may be affected by this. We can identify anyone that's or any groupings that are more effective than others, and that will enable us to plan mitigations for that. We're not at that stage yet, but that's an important part of the transformation process.
Okay, thank you for that. A really good question. I've got time for one more question, and the gentleman here has had his hand up for a while.
Yeah, I listened to the presentation. It didn't have great emphasis on money, but then most of the questions subsequently have. And it seems to me that you should be with NHS providers who are saying that it can't be done within the funding. They've said that through the media, which is remarkable for such a public body to make such statements. And it strikes me you've got an impossible job. You can't save that amount of money by the projects that you're engaged in. I know that the view of the STP is there are no red lines around any services, meaning that they could shut anything, which I think people find very alarming. And simultaneously, as you've replied, you want more money on certain services and mega cuts elsewhere. And you said you're going to rely more on GP services, and your video shows that your GPs are retiring. You're going to put more and more pressure, and already most of us, if we ask for a GP appointment, we're told which week it will be in. It's ridiculous. You're living in a fantasy world. Meanwhile, as one previous questioner asked about Devon County Council, the reason you keep them away, as you did from the Your Future Care services, is because they'll tell a completely different story. While you're talking about mental health, they're cutting their mental health provision. They're worried about their social service provision. They're cutting back on public health, which this whole project relies on. And bodies like care homes are faced with the threat of closure, as I believe Panorama is going to be telling us probably while we're here. This is not a serious policy at all. It's living in a fantasy.
The panel like to respond to, I think it was points from particular questions, but if you'd like to respond.
Okay, I think I addressed some of it earlier, so I will try and expand on that. So in terms of the allocation of funds we're given from the government of the day through NHS England, as I said before, we are party to those representations to try and ensure that we maximise the amount of money that comes to the NHS. But that's not our prime role. We have to work within the allocation that is set for any particular period of time. This plan, this set of measures, helps us to make best use of that. As I said, will we save all 500 million by 2021? I can't stand here and say that necessarily we will. But if we take these steps, we will make better use of the resources we've got than we currently do. We will have safer and more sustainable services across the piece. We will have addressed some of the inequalities, and that's a step worth taking. The issue of Devon County Council, I already answered that, so I'll say that again. I'm not here because we've kept them away. I have no problem with my colleagues from Devon County Council or Plymouth or Torbay being on the platform with me. I actually don't have a problem if other partners in the system have different things to say. The most important thing is that we're working together on the issues, and that will be better for the population in the long term. We have to work together. We are working together.
Thank you for that response. I'm going to take one very last question. The lady did have a hand up and I didn't recognise it. So it's the last question before we move on to the next session.
Yes, I've got 2 points which I'll make really quickly. The first is, do you think that the reason that you are lacking in trainees is because of the cost of getting qualifications now that you have to pay for university tuition, and the fact that this is now going to be extended to nurses is going to make the situation worse rather than better? And my second point is not related to that at all. It's in the original presentation, you did say that that services should be delivered as locally as possible, and if that is the case, is it really a good idea to be closing the community hospitals? Would it not be better to be upskilling them and having perhaps roving consultants who could go to them all and provide the service to the person with the stroke? I know this is outside Exeter, but a stroke in Woolacombe can get to a community hospital in Holsworthy quickly, rather than having to come all the way here to Exeter where there possibly isn't a space.
Popular question. Panel, would you like to respond?
I'll respond, on your question about training and the cost of training. In medical training, attending medical school, tuition fees have been a requirement for a number of years now, and there has been no reduction in the popularity of medical training. Not noticeable, and there aren't vacancies in medical training programs, so there are still lots of people who wish to train to become doctors. I can't, however, comment on what the impact on nursing training will be of introducing a similar fee system, which is only just coming into play now. So I can't comment on that.
Yeah, I think part of the issue is that they're oversubscribed training places, but it costs £200,000 or something like that to train a doctor. So what we haven't got enough of, potentially, is enough training posts at medical schools. We've got enough people who want to do it, and they're oversubscribed, but we don't train enough people, and it's very expensive. So it's another decision for the government to make about where they put their resources. And they are opening up the number of training posts in medical schools next year by a considerable amount. But the problem for us is the situation we're in at the moment is the planning that went on 10 years ago for the number of places in nursing, number of places in medical school. So at the moment, it looks like we've possibly got the planning wrong, because we're struggling to recruit. And this isn't a Devon problem, it's a national problem. That Devon's better off in many ways than many other parts of the country. So we've got difficult issues. We can't get away from that, and we've got to try and deal with some of the ways that John was talking about earlier on.
And again, just picking up your second point about availability or access to services, all of these reviews are dealing with services which require the presence of people at the very highest, with the highest level of skills and training in within a sort of a short time frame for services. Again, I'm not going to comment. I'm not. These reviews are not related to the ongoing care of people with long-term health conditions. These are an acute presentation and requiring a number of skills, equipment, etc. So, whilst it would be nice to think we could deliver those services in more places, I think at least we have to make sure that we can deliver them sustainably in the locations we already have them, rather than looking to spread the availability of those acute services any wider.
Okay, could I thank everybody for those questions? They were articulate and probing, I think, and certainly given the panel food for thought. Can I also thank the panel for their responses to those challenges? We're going to move on now to the next and the final part of the session, which is the tabletop discussions. And in the packs that are on the table, the large ones again, there's 2 questions. And we'd like to spend, it's probably going to be nearer 45 minutes than an hour now, we want to finish about 8:30, addressing those 2 questions. On each table there should be, and I think there is a facilitator who will help you through those questions and will take detailed notes. If anybody would like to make their own notes in addition to that, please feel free to do so, and we'll make sure that they are passed on and part of the review. Could I also say, I think there's we are switching around, there's only a couple of people on one of the tables, but feel free to move around and join other tables if you wish. But I think that's enough for me. I'll let you get on with the questions. I think myself and the panel members will probably wander around the tables and listen in and hopefully contribute to the debate. Thank you.